And here we go. Okay. Hello, everybody. This is Dr. Centeno, and Dr. Henderson, as you can see here, is with us. Listen, I have been treating craniocervical instability patients and upper cervical injury patients for many years. And as I got deeper and deeper into treating craniocervical instability, came across Dr. Henderson's work, his published work, and was very impressed by what he had published in this space, some of the concepts that he introduced to this space. And then over this last year, I've actually gotten to know him a little bit personally, and we've been trading patients back and forth. So I thought it would be fantastic to have him on where he could answer questions about surgery. So I'm just going to let really Fraser tell his own story. Fraser is a neurosurgeon, but he's got a super interesting story about his background. So Fraser, why don't you introduce yourself and tell everybody the same interesting story you just told me?
Well, first, thank you for inviting me, Chris, and it's an honor to be here. You are the best at what you do in the world. And funny, we've been coming at this problem from different directions, but I think we kind of probably agree on what's happening, probably almost every detail. And well, you asked me to tell my story. I grew up in the Philippines, Hong Kong, and Australia. My father, after World War II, he was an aviator on the Enterprise, and after the war, he went back to Asia in the United Nations, and then left that and set up a small shipping company and was involved in shipping cattle from Australia to Asia and then other products between Asia and the United States. And we applied for and eventually acquired a block of land in the northwest of Australia at a time when no one wanted to be out there. In fact, we were the first non-Aboriginal family to enter that valley that we eventually acquired. And it was in the family until about 10 years ago. And
you guys raised cattle there?
And so we had wild cattle, and eventually bred in Brahman cattle and whatnot. But I went to school in Sydney, but then worked on the property till I was 20, and then came to the University of Virginia, went to medical school, was in the Reserve Marine Corps, and then switched to Reserve Navy when I was admitted to medical school. And when during medical school, I went out to Beirut in 1983 and took care of the survivors of that horrible disaster. And then in 1990, I went out to the Gulf Wars, the neurosurgeon for the 4th Marine Expeditionary Brigade. I did a fellowship in London on skull base and craniocervical junction, and we saw a lot of connective tissue problems, and that was my entree, I think, into this whole process. And then I went to Georgetown, where I was director of neurosurgery of the spine and craniocervical junction. I became professor, and then later went into private practice. And I've stayed academically active. Like you, Chris, I've published about 130 papers, and recently published a book called Symptomatic with Claire Francomano and Alan Hakim. And it's a chapter on every symptom of Ehlers-Danlos syndrome and how you make the diagnosis. There's a little a short report on an illustrative example of each symptom, how we worked it up, what was the differential diagnosis, how we treated it, and an algorithm and a short reading list. So there's 2 volumes of information packed into 700 pages there. And
look for patient-directed physician threading a needle.
As you know, of course, most of our patients are pretty well educated, and they can understand easily 95% of the book. So it's for typical patients and for any doctor. In general, our patients seem to know more than most of the doctors they contend with.
That's true.
So I'm sending you a copy of this. You'll know most of it, but hopefully you'll enjoy looking through it.
Well, thank you.
Okay.
For that. So basically, so that's how you got into CCI surgery. One of the things that I found amazing was when I found your paper on the level of stretch versus the clivo-axial angle. How did you get into that research? Because I find that super fascinating because it obviously involved, I'm assuming, some computer modeling. So how did you do that?
Well, it's interesting that was interesting to you as well, you know. But I've invented I have about 15 patents, and one of my first patents was a device for fixing the cervical spine. And I got into finite element analysis in building that device. And then I thought we could use finite element analysis on the brainstem and spinal cord. So I built a model for that, and we worked with an engineer in Michigan, and we built and patented a model and where we predicted excess strains patterns in the brainstem and spinal cord. And in one of the publications, one or two of them, I showed examples of how the patients got better, and their mathematically predicted strains paralleled the improvements in symptoms and pain and quality of life. The only problem was I couldn't generate enough interest in the neurosurgical community. People would hear my lecture and they'd say, "Oh, that's interesting," but they never, unlike, say, you and I, who understand the importance of mechanical strain in the nervous system, it's not in the general vernacular of the medical community. So I didn't go much further with it.
Well, yeah, blew me away. So just so everyone understands what we're talking about here is that Dr. Henderson has a paper that looked at the clivo-axial angle, so basically degree of rotation of the skull versus the cervical spine. And obviously, as you come forward and the clivo-axial angle goes down, you're going to see more stretch across that medulla and upper cervical spine. And what was amazingly interesting, Fraser, was that there was a recent study by Nicholson et al., an upright MRI, looking at normal, and it tracked very nicely with your model. They had the lowest normal range at 128 CXA, and they didn't find anyone in the normal control group that was lower than that. So it tracks very nicely, because what Fraser's model showed was that, or Dr. Henderson's model showed, was that as you got to 120 is when you really saw big problems happening. So how do you use that with the work that you do? So if someone comes in with a low CXA, how do you approach that?
Yeah, so, one problem with these patients that we see is they all look so good. They're smart, they come into the office and their adrenaline is up and they look well. Of course, they go home and they crash for 3 days.
Yeah.
But when they come in to see the doctor, not just me, I mean, any doctor, they look well. And so every doctor thinks that there's nothing wrong. And even when I look at them, I have to rely on the knowledge of the symptoms and the congruent neurological findings and the metrics that we've established. And then I rely upon those things to know what the what the course of action will be. So when they meet those thresholds of pain, disability, symptoms, neurological deficits, and the radiological findings that fit, then we know that those patients will improve with surgery. Now, when they're, does that answer your question?
Yeah, absolutely. So yeah, why don't we'll go and take some patient questions. One more thing I wanted to add, just to let you know, was that same paper looked at translational BAI. And I'm not sure if you remember, but way back when you wrote in a paper that the number should be 1, but we'll add in 3 just to make it, call it fudge factor there. And so the number you had pegged was 4. That's the number they found, 4.
All right. Yeah.
So that was also prophetic there. But anyway, I'm fanboying here. So let me go to some of the patient questions. One patient wants to know, what's your preferred form of imaging for CCI? So what's your imaging workup? Patient comes in. What do you want to see?
Yeah, I like to see an upright flexion extension MRI of the cervical spine. And, if you're lying flat on your back, you can have a completely unstable neck, but it'll, if you're lying down, it may be perfectly aligned. Mm-hmm. You have to stress the ligaments a little bit. And so the upright flexion extension does that. You can do a flexion extension lying down, but that's not really physiological. When they're sitting up, the stresses are a little different, and that is physiological. So the best is an upright flexion extension MRI, and then I measure we'll be going through them, I suppose, the basion-axial intervals to determine the translation present. The other film I like is the rotational CT scan. And we, in the CT scanner, the patient will lie flat on their back and then turn the head full left, and they'll be quickly scanned in the upper cervical spine, and then full right, and they'll be scanned again. And then we measure the angle between C1 and C2. And if C1 turns too far on C2, that's called rotatory subluxation. And if it goes a little bit more, you can actually get a dislocation, which could be life-threatening. But when they're subluxing, they're attenuating the vertebral arteries and not getting enough blood flow to the brain. And they're also straining the lower brainstem and spinal cord. And they're also causing stretching of ligaments that may be causing pain, etc. So I like that rotatory CT scan.
And what's your cutoff there for C1, C2 rotation?
41 degrees.
41. Gotcha. Okay, I got lots of questions here. Let's see. One patient wants to know whether you can do online consultations. I don't know. What do you do those? I'm doing them with some physical therapists that I work with, and when they find a patient they believe has craniocervical or atlantoaxial instability, I have a relationship with them where we do a Zoom conference, and I meet the patient and I hear their symptoms, and then I say, well, you sound like you might be in the ballpark for having craniocervical or atlantoaxial instability. And in that case, I'll say, you ought to come see me and get a flexion extension MRI and if I think it's atlantoaxial instability, a rotatory CT scan. So I don't, now the Zoom conferences are great, and you can get about 70% the way there. Yeah.
But I have often been wrong. When I saw the patient in person, I found that my original diagnosis was incorrect, or you have to see them in person to make a good diagnosis, and you need to do a very careful exam, and that tempers the importance I put on the specific symptoms.
Yeah, I agree. Maybe we're old fashioned, but there's nothing like, a physical exam to see what's going on for sure. Um, so Fraser, what do you think the success rate is of fusion? I know it's probably pretty dependent on what type of instability, how much instability, how severely disabled the patient is at start. But what's your overall sense of what that looks like?
Yeah, it's been improving. I thought I was really good at this 15 years ago, but what we're doing now, and I work with a colleague, I found, and you work with Dr. Schultz, and I mean, working with colleagues who understand every nuance is great. But I think that our fusion rate is close to 100%. We see a significant improvement in all of brain fog, weakness, sensation, vertigo, dizziness, fatigue, and most of the symptoms. We're getting. There've been a few reasons for this, and one is I think we've worked out all of the potential problems and we avoid them. And two, we're extremely careful in surgery. We lose almost no blood, and we even close the wound together. It's so that we're not having any wounds. We've worked out how not to have wound complications. If I consider every case kind of a blessing, when they do well. I don't want to take all the credit for that, but they are doing. We do get them out of bed 3 hours after surgery, and they have to walk to the bathroom, and they realize that they're actually in pretty good shape. And many patients are actually leaving 1 day after surgery, which is, I never would have believed 10 years ago when we had them in the house for 7 days,
So 10 years ago, it was a week inpatient.
On average, or maybe 6 days. Some patients stayed for a long time. Some were leaving in 3 days, but if you averaged it out, it would be, about 6 days. Now the average is under 3 days. So patients are, and we're getting them off their opiates very quickly. And my goal, I'm not interested in doing the surgery. I'm interested in, like you, Chris, rehabilitating patients back to a real life. And if they did well with surgery and then went on disability, I would quit tomorrow. Not interested in that. I'm interested in, and that's why I follow them as long as they need to make sure they, not just as far as this surgery is concerned, but there are other comorbid conditions are appropriately treated, and they go back to college or back to raising their family or back to work, whatever. That's my goal.
So these days, what would be your most common surgical procedure that you perform? I know obviously everyone's different. Some people need more fusion, less. But what's the most common?
Yeah, it's funny. When I, back in the Navy, I think I had 70 procedures that I could do, from cranioplasty and the pediatrics to peripheral nerves. And now I do 90% of my surgeries are about 8 different surgeries. But the most common is C1, C2, closely followed by OC2, which is about equal to cervical discs and tethered cords and thoracic fusions. They're actually they're all about equal. And then I do some shunts for intracranial hypertension, lumboperitoneal shunts, and in those cases, about 90% of what I do. And then there's case, but I'm still doing trauma calls. So I do cranies for hematomas and tumors, and occasionally.
So yeah, so how did they loop you into still doing trauma call? That's some work.
Yeah. Well,
God's work, really.
Well, I was heading to Africa to do some missionary work, and a lot of it's 1/3 of it is trauma. And I realized that I had gotten away from trauma and I was getting too specialized. So I thought I'll start doing trauma call again. So for the last 6 years, I've been doing, well, actually, even before that, I was doing trauma call at other hospitals, but we didn't do that many craniotomies. Now I'm at a trauma hospital. So when you're on trauma call, you see gunshots and you see everything. So now that I've had my fill of it, I'm still doing it because when I come off trauma call, life is like a vacation.
Yes.
It's like taking a cold shower. When you get out of the shower, life is good. So it's I like to just also pull my weight, at the hospital and just keep my oar in, but I don't know how much longer I'm gonna. It's painful being on trauma call.
Yeah, I would imagine. Here's a super interesting question. I've seen this a couple times where, you would assume that the CXA obviously gets lower in flexion, but there's a patient population out there that does seem to have a lower CXA in neutral. What are your thoughts about that? And its relationship maybe to lordosis, or what are your thoughts?
Yeah, well, you're the only person who's ever mentioned that, and I've seen that, and I don't know what causes it, and I'd like to talk to you about that sometime. I don't know. It's biomechanical issue, and but I'd be interested in your thoughts. I can't give you a good explanation for that.
Gotcha. Yeah, I tend to see that if they have a hyperlordosis, and obviously a more retroflex dens, that sometimes you can actually get a lower CXA in neutral. That's sort of what I've noticed through the years. Here's another interesting patient question. How often do you use digital motion X-ray? I know patients probably walk in with them. Is that something you consider? What are your thoughts with that?
Yeah, the DMX, digital dynamic fluoroscopy, is very low radiation, and it's good for looking at the whole spine. But I find it useful, especially for C1, C2. And a couple of papers have talked about 20% of atlantoaxial subluxation occurs due to excessive lateral displacement. And so if you CT someone, or if you fluoro someone with their head tilting one way or the other, you can measure pathological slide of C1 on C2. And if that sliding, that translation, exceeds 1.6 millimeters, it's abnormal. And I again go with the 4 millimeter rule, that at 4 millimeters it's clearly a pathological translation, but you could easily go less than that.
Gotcha. So
I think it's accurate. Yeah.
So you do look at it here. Let's see. I'm just trying to pick out some good patient questions for you here. This an interesting one. It sounds like you work with some physical therapists locally. What is their strategy or your rehab strategy for your patients that have had surgery? And it sounds like you probably send, obviously, a lot of patients to PT before surgery as well.
Right. Yeah. So I work with a some really great physiotherapists, and sorry, I call them back. The but before surgery, I ask patient often to wear a neck brace and do isometrics. Now, if a patient's been doing that for 6 months, and very often they've been suffering with this for years, then I don't make them go back and do the same thing all over again. But preoperatively, it's primarily isometrics, posture, core strengthening, and they're the main things. I think postoperatively, focusing on excellent posture, getting the head back above the shoulders, and the isometrics and stabilizing the neck with the goal of going back to the operating room on fewer occasions because of neck instability lower down. I encourage people to minimize their neck movements after surgery. I'm not concerned about the operative levels, which are perfectly stable without a brace after surgery. But typically, the C4-5 level, mostly at C3-4, C5-6, less so, are usually hypermobile. And if the patient moves their neck around too much, they're more likely to degenerate excessively at those levels and may need more cervical spine surgery. And I found in a paper I published about 10 years ago, or 8 years ago, with a 5-year follow-up, 60% of patients needed subaxial, i.e. below C2, cervical fusions. Anyway, since then, I've been encouraging people to move their neck less, and that number has dropped to about 30%.
Oh, so a big difference there.
Yeah.
Gotcha. So this is one that'll be near and dear to your heart because it's near and dear to my heart, and that is, why does my neurologist not know enough about CCI to help me refer to someone like you both doctors here? And I think obviously what it brings up is this huge disconnect still between the medical community on CCI. So what are your thoughts about that? What causes that? Is there any way to fix it?
Are you talking, you mean congenital stupidity, or no? No, actually, it's just not being exposed to this population, you know.
Yeah.
I don't know how you became involved, but both of us learned, recognized early on that there's this group of patients that had something going on and the medical community was missing it. And I happened to have done a fellowship in craniocervical spine. So when I went to Georgetown, I took care of all of the unusual problems at the craniocervical junction. And so I was seeing EDS patients without even knowing their diagnosis, but recognizing the problems with Chiari and craniocervical instability and so on. But most surgeons never, see those patients seldomly. And furthermore, it's not, most surgeons don't like to step out of the middle of the road, and they don't want to go out on a limb. If it's not something that everyone else does, they don't want to do it because they might be criticized for it. So they've made I feel like they've decided that they are going to be middle of the road, but more than that, they're going to refuse to even recognize the possibility that these other problems are existing, and a lot of doctors are even arrogant about about their refusing to accept what they don't understand, and that's what I find not acceptable. Doctor ought to have an open mind, especially about the things that he has no knowledge of.
Yeah, it reminds me of back, who is it? Was it Colin Powell that said there were unknown unknowns?
Yeah.
Something like that.
Right.
Here's another interesting one from this patient. I guess he's describing it as air hunger or respiratory depression or changes in respiration. How often do you think that can interface with CCI?
I can't with CCI, but we also see it. And there's a chapter in the book.
Oh, yeah, symptomatic.
Actually, 2 chapters. One, if you have instability at C3-4 or C4-5, you can have injury or malfunctioning of the phrenic nerves so that you don't get full diaphragmatic excursion. So these patients complain of not being able to breathe deeply, and they go to their doctor, even their pulmonary doctors, and all the testing looks pretty normal. So they're told there's nothing wrong. But the problem is incomplete phrenic nerve activity. And so so it can be a C4-5 instability or C3-4. As you said, it can also be brainstem related, where they have some apnea, sleep apnea, and decreased nucleus salutaris activity that generates the breathing action. But there's the third place where this can happen is instability in the upper thoracic spine. And many of these patients have instability at the very top of the thoracic spine, which is very atypical of the usual scoliosis. And I've operated on a number of doctors with this who were having difficulty breathing and walking and severe pain. And the imaging looked pretty normal, but you had to see the thoracic kyphosis and scoliosis and recognize the rotation in the upper thoracic vertebrae to understand that they were suffering from a high thoracic myelopathy that was causing problems with the rib cage opening, and so they have pain and difficulty doing a deep breath, upper thoracic.
Gotcha. Yeah, that's an interesting one. We've seen certainly a lot of patients with, obviously EDS patients with rib cage, also related issues. Obviously, as you know, that phrenic nerve not too far from the sternocleidomastoid as well, so it kind of lives under there. So let's see, Ben, this is another interesting one. What are your thoughts? Is it possible to know which part of the brainstem relates to specific symptoms? So could you predict, let's say, looking at someone's MRI, that they might have one symptom pattern over another? That's one I'm not sure of.
Yeah, the nerve tracts in the brainstem are so intercalated that I think you can only get a broad brushstroke of understanding for a given kinking of the brainstem. I don't think I could isolate any specific symptoms based on the degree of or the location of the medullary kinking.
Gotcha. Yeah, I couldn't answer that one. This is kind of a long one, but I think what Eric is asking here is, at the end of the day, is there something that you do once you fuse to make sure that C1 and C2 are properly aligned when you fuse them? So I think, very long question, but I think that's what he's asking.
Yeah. Usually by the time we've positioned the patient, and we spend some time getting them perfectly positioned, C1 and C2 are lined up. And if they're not lined up, then we can't get a good fluoroscopic image. So we spend 10 minutes and get them lined up in the very beginning. Then as we put the screws in, if there's any subtle differences, we'll try to eliminate them intraoperatively. And by the time we've finished, we've eliminated, like 95% of any misalignment. So anything that's left is not significant.
Gotcha. So quite a bit of working on it as you go.
But we don't use 3D navigation. I think that some of the bones we operate on are so small, some of the pedicles, that the navigation might not be as accurate as what we're doing, which is studying the films and then the fluoro, and then putting that screw in the optimal place in the correct depth, and the two of us, 4 eyes, working on it. And not the problem is if there's little movement of migration intraoperatively, I'd be concerned that the navigation might be a millimeter off, and that would be too much for us. Yeah.
Gotcha. Here's another interesting one. Do you have a list of physical therapists that you work with?
Yeah.
Obviously, many of your patients come from all over.
Yeah, well, I can rattle some of the top names off. Michael Healy in Providence, Rhode Island, and J.R. Buckland in Frederick. He used to teach, and he's brilliant. Jan Dommerholt in Silver Spring, in Bethesda, Maryland.
I know Jan. Yeah.
Yeah. And Ren Lister Proctor near Greenville, South Carolina, and Marcia Preto in West Palm Beach, Florida. And so I'm sort of pointing geographically as I.
Yeah.
And of course they've got some fabulous people down there in Charleston, South Carolina. Does that answer your question?
Yeah, I think that's good. You probably have. It sounds like you've got a very specific list of therapists that you work with. I know Jan from many years ago. Probably 20.
Right. Wow.
So, Robert, do you use intracranial traction at all in making your diagnosis, or invasive traction? Is that something you've ever used, or what are your thoughts on that?
Yeah, I never used it, and I think Dr. Bolognese has probably worked out a system that works for him, but I know that if someone did traction on me, I'd feel a lot better,
Yeah, I would too.
So I, and also we're trying not to stretch the spinal cord or brainstem. We're trying to just get it aligned as straight as possible. So there's a little bit of traction involved in the reduction, the alignment. We're applying a little bit of traction and posterior translation and extension, but it's not overt intracranial traction. We're not trying to stretch the neck out. And if anything, to get a more solid fusion, we certainly don't want to increase the space between the facets of the condyle of the skull base and C1 or C1 and C2. We want them all close and together. So does that answer your question?
Yeah, I think that does. Here's another interesting one, laser spine fusion surgery. So maybe just use of lasers in spine surgery. Is that something that you do? It's a gimmick. What are your thoughts there?
Well, I was doing lasers, I started using them about 25 years ago for tumors in the spinal cord and very, things like that. But for Ehlers-Danlos syndrome, for these issues, I can't see a purpose for laser work in the spine. And for things like disc surgery, I don't see the purpose of it. Lasers are incredibly precise and effective, I think, for small things, but not for bigger things. And we're talking about, generally, well, anyway, you get my idea.
Yeah, I got you. So just a shout out to some of the missionary work that you do here. When you go and do missionary work like that, I would imagine you see everything, right? Is that, tell us a little bit about that.
Yeah, we saw horrible brain tumors, craniocervical, all the typical craniocervical problems and trauma and atlanto-axial instability and cervical subluxations, fractured vertebrae, gunshot or arrows to the eye.
Arrows to the eye that entered the brain?
That go into the eye. I suppose it'd be the front of the brain, But,
yeah.
And
so
then,
what is the key to getting that arrow out?
Well, you got to come in through the top and take it out in both places. And then tumors in the spine and shunts, pediatric things. It's kind of frightening. It's not. I can't say. I enjoy my work now. And but it's a little bit scary when you're out there. And one day, I remember one case I was doing a spinal tumor, and I asked them to tilt the table to me a little bit, but then the machine got stuck and it just kept falling, and I had to hold up the table, to stop the patient falling on the ground,
Oh, God.
And so on the one hand you have some really good equipment that's donated to them, and then other hand some of the equipment is very primitive, and sometimes the power goes out, and the everything it's not quite as sterile, and everything we're doing, but the patients generally seem to do very well. But it's a tough.
And I imagine, probably. So, for example, one of the things as we started to see more German patients, I've noticed about German patients is that they are incredibly quick out of recovery. You probably see cultural differences like that in how they recover. Is that something that you see?
Yeah. Well, I think they were not really so quick getting out of the hospital, but they would be quick getting off pain medicine. For instance, after a major surgery, they might have a Percocet.
Yeah.
One Percocet a few times a day. And we didn't have the heavy duty pain meds for them, but they were very stoic. And even after great surgeries, they'd be stoic in the Thanksgiving and stoic in their pain, which is,
Here's another interesting one. Caleb, is it possible to have a brain drop feeling withstanding with CCI? Is that a common complaint? You've got your book on symptoms there. That's obviously not one I hear a lot, but what are your thoughts?
The feeling of a bobblehead.
Yes, is big.
Bobbleheadedness, and that's just ligamentous instability. But I think as far as the brain drop, no. That's a new one.
Yeah, that one I don't hear as much. I mean, obviously it could be decreased intracranial pressure, I guess. Let's see. This is an interesting one. I don't know if you even know about this, Fraser, but I took some time to try to type CCI and came up with a typing system. We'll publishing on that probably sometime later in the summer.
We should, we ought to maybe collaborate, and at some point, you're probably close to publishing that.
Well, no, actually, it's being written now, so I would love to collaborate on it.
Yeah, I mean, we deal with the same problems, and presumably I deal with the ones that are not going to respond, and we need to work out, where that interface is, and maybe you should come to a conference we're having in Rome. Actually, we're going to have some various perspectives on CCI.
You're going to be in Rome next week?
In November.
Oh, November. Okay, gotcha. I will be there next week. So
okay, no.
Okay.
I think it'd be useful if we, if you're subtyping them, that you've gone further than I have in that. I just say unstable, or I do differentiate between radiological evidence of instability and instability, in the sense that you can look radiologically unstable, but if you're not in pain and have neurologic deficits and the right symptoms, then no matter what the radiological appearance is, there's a gray zone there where we might not call it unstable if the patient is normal. The patient has to be expressing pain and symptoms before we'd call it unstable. So the radiological diagnosis is only part of the classification.
Yeah, I would agree. Well, I'll send you what I have there, just so you can kind of get a sense of what we're doing. But that would be wonderful, obviously, to get a collaboration on something like that. This is another interesting one that follows there, and that is really what you just talked about, right? We see some people whose imaging doesn't look great, but they're not that functionally disabled. And we see patients on the other end of that spectrum, patients who maybe their imaging looks better, but they obviously seem to have issues, and they're very, very symptomatic. So what are your thoughts there? What's causing that, or what do you think's causing that? Clearly radiology is just, as you just brought up, is not destiny. So why do we see this dichotomy there of some patients more impacted than others?
Yeah, well, there's so many factors involved. It's not just the ligaments. It's the shape of the bones and the amount of translation, and in some patients you might have a very kyphotic clivo-axial angle, but there's less medullary kinking, less kinking of the brainstem because of the shape of that patient's brainstem. It's just different. And there's some people who have attenuated blood supply. When they slide the wrong way, there may be a relative ischemia to the brainstem and even the back of the brain. In others, the blood supply might be quite normal. In some patients, the ligaments are really loose, and they're not just sliding forward. They may be twisting and sliding sideways, and and they can be. So some people are just floating on C1, and there's so the thickness of the ligaments and the strength of the muscles and then some people may respond to pain differently. Everyone's pain obviously is different, the length that you've been dealing with this, and the psychological behavior you bring to bear on the problem. For instance, if you're in a wartime in a battle situation, you don't feel pain, so the environment you're surrounded with will affect how you perceive the pain, and your sense of hopefulness and validation. And a lot of what we do is we're able to validate because we understand what's going on. And the validation is so important, because if you're told by 20 doctors there's nothing wrong with you, that could that would begin to wear on your psyche. Certainly would mine. And
I've told patients it's like being a pinball. Probably it's like being a pinball in a pinball machine. You go from specialist to specialist to specialist. That's probably what it feels like.
Right. Yeah. And does that answer your question?
Yeah, I think so. So there was another interesting one from Ben. Does the brainstem have capacity to heal after being stretched? What are your thoughts on that? If someone has been stretched for a long time, obviously there's going to be a certain percentage that don't, but what are your thoughts on the capacity to heal?
Yeah. So in the last 20 years, we've learned that the adult brain retains the plasticity, or the ability to form new connections, and to heal neurons. So the neuronal cell body is still alive, but there may be a disconnection, an injury to the axon or the myelin around the axon, and that has the ability to heal. So I think brainstem injuries, and most of these patients, we find in surgery they have very prolonged auditory brainstem reflexes, which imply brainstem injury. And I think it takes several years for them to heal. But so patients ask, how long does it take me to heal from this surgery? Well, the bones heal pretty quickly, and that's the easy part. And then the nerves and the brainstem and spinal cord have to heal. But then the connections that go up to the cortex and the brain, and the neurological behavior, the reciprocal connections between brain cortex and cerebellum and brainstem, they all need to heal as well, because they've gradually become impaired over a decade. So all of that takes about 3 years. But I'm finding that most patients, if they can get their treatment and then keep their neck in a stable position, and then try to get back to their studies, and just gradually improve their health, in 3 or 4 years, most of them are getting back to a useful and happy lifestyle.
Interesting. That's good to hear that you think it's at that 3-month mark, or I'm sorry, 3-year mark.
Yeah.
This is actually one of my patients, very super interesting situation. Severe C1, C2 arthritis on one side, that's so severe that it actually pushes into the posterior oropharynx, where there's a visible bump.
Wow.
From the anterior facet arthritis. And I told her possibly, we can treat the symptoms of facet OA. I think what she's asking here is, have you ever seen a case like that, where obviously there would be the fusion part, but then would you at all attempt to do anything about the lump in the back of the throat part?
Well, I think you sort of suggested the answer, which is that when you stabilize the segment, very often the osteoarthritic changes gradually regress, and they'll be eaten up by osteoclasts and whatnot. And over time, those inflammatory processes can recede and the bump could go away. As far as removing the bump in the back of the throat, I've never had to do that. And keep in mind that that would be close to the carotid artery. And so it'd be good if it went away on its own.
Yeah, exactly. Yeah. Sounds
but
like
I certainly did, 20 years ago, I was doing a lot of transoral, odontodectomies, and even took out some tumors from the front of through the mouth. And I haven't had to do that in a long time, but just hasn't been necessary. And I'm not doing the tumors now,
Gotcha. So the book, Symptomatic, I found it on Amazon. He's asking, is it on Kindle? Yeah, looks like there's a Kindle version.
All right. It's
I'll share that.
I'm not just saying this. I was very sorry that they charged so much for the book. We were hoping it would be, like $70, $80, but the amount of work that went into this, with thousands of hours, and we literally took the world experts on actually, Chris, you should be in this book. I'm so sorry. Next one that comes out, you'll be in there. You'll be the first chapter. But every chapter has a couple of authors, and then I rewrote all the surgical chapters to make them coherent, succinct, and complete. And then the other editors also edited each chapter so that there's no bias and everything is consistent. And my son, who is between companies, spent 6 months going through every chapter with a fine-tooth comb, making sure that the grammar, the bibliography, every detail was consistent throughout the book. So it's the most heavily edited medical book in history, I think.
That's true. A lot of cross-editing, and then edited on top of that.
Yeah.
So, guys, on the screen right now is where you can get the book on Amazon. There is a Kindle version. So if you I just typed in on Amazon "symptomatic book," and it came right up. So just to let you know that that's on there. And I think we'll take one more question here. Well, this is when I get enough, so let's throw that one in there. Have you seen basically facial nerve disorders, either trigeminal neuralgia or cranial nerve 7 type facial palsy in CCI patients? I certainly see a lot of trigeminal overlap. But what are your thoughts on facial nerve or on the facial nerve component and cranial nerve 7 issues?
Yeah, that's a really great question. First, concerning the weakness, I think that is probably brainstem related and something akin to a lateral medullary syndrome, Wallenberg partial. A number of patients have mild facial paresis. And I don't think that's the facial nerve as much as a brainstem at the brainstem level.
Gotcha.
Secondly, most of the patients have what's called a Dejerine pattern of facial sensory loss, where they have hypoesthesia around the outside of the face. And that's due to upper spinal cord compression or torsion or strain. And this would normally, most neurologists would think that anything on the face falls into the distribution of the trigeminal nerve. but the as you know, Chris, and you probably explain to your patients, the trigeminal spinal nucleus descends in the spinal cord to C4. So that nerves at C3, C4, even C2, the pain fibers intermingle with the same pain fibers of the spinal nucleus, which is pain temperature of the trigeminal nerve. So that I see, especially patients with C3 nerve entrapment, sometimes because of the scar above, can cause pain on the face, even around the eyes and around the nasion, in what is clearly a trigeminal nerve distribution, but that came from the C3 nerve.
That's super fascinating.
Yeah.
Okay, well, I think we did a whole hour here. We could do 5 hours on the number of questions that we have. A couple things here. Number one, I really want to thank Dr. Henderson for spending his time with us. He actually has some company in town, and he agreed to kind of move some things around to be with us this evening. In addition to that, Fraser, I just have the ultimate respect for what you do and all that you've published. So I want to thank you on behalf of this CCI community for that. And then hopefully at some point in the future here, you'll do this again, because it was wonderful to spend this hour with you.
Well, my feelings exactly reciprocally, and I'm honored to be on the show, on the program. And I hope we can work together and come at these things from different perspectives and get some greater truth there.
I will be sending you that typing system, and we'll be going back and forth on that one. And I think it was Kim here who recommended that. So thank you for doing that. And that may be the beginning of a great working and publishing relationship there.
Excellent. Okay. All right. Take care.
Okay.
Great questions, everybody. All right. Take care.
Thanks.